that's been our experience, and now I think we'll move on to some questions and hopefully shed some more light here.
Thank you. We're now going to begin answering the questions submitted during today's presentation. Asking the questions today will be Dan Actor, Director of Marketing at EKOS.
Thanks very much. So as the questions come in, it looks like there's about 3 different areas of focus for these questions. Questions about PERT, questions about patient selection for EKOS therapy, and then a couple questions on treating with EKOS. And so I think that's the order that we're going to go in. First question on PERT is who is the main PE team contact at Sanford?
For us, it's our vascular group are the primary evaluators. We're kind of champions when we put this together, and so we stepped up and are the primary evaluators. So the way that we run it is 3 PE, our number for our main call line, and that's a 24-hour number. So when during the day, that'll come through our triage nurse in our clinic, and then through the on-call. At night, it just comes directly to us. But that's the way that we run it, and I think most primary evaluation teams are probably either in internal medicine or hospitalist, or not hospitalist, but pulmonology. And running it, you just have to look at what's the best way. If you have a great, slick method already that's in place for the primary evaluator call team, I think that's a great number to use. A lot of places, though, will develop an individual number, and that can go through to a triage nurse, which I would highly recommend if you can get that in place, versus directly through to a doc. But that's another way to do it that I see.
Okay. How often does Sanford's PE response team get activated in, say, a month? And then what's been the change in the volume of PE calls since Sanford's program has been started?
Yeah, so initially we were just kind of getting called randomly by some ER docs, saying, hey, do you know any treatments for those patients? They're not looking good. And that's kind of how we started early on and explored, different treatments and how we started to explore EKOS. As we develop our team, the numbers vary dramatically. You'll seem like you haven't heard of PE in a couple weeks, and then you'll have like 3 in a day, So it comes in fits and stops, as we say. But on average, I think we're probably, getting called on 2 to 3 PEs weekly, and we're probably intervening procedurally on probably 1 weekly. And this is through our system. Now we have 12, I think now 13 ERs that come to our place, small outlying hospitals, and family practice clinics as well that kind of funnel through to our ER. So that's the size of our location, our hospital, and we have about a 350-bed hospital as our primary hospital here. So those are the numbers that we're seeing. But again, it varies dramatically. At some point, it seems like all we're doing is lysing PE patients. We have some weeks where like, my goodness, we need more. We know more EKOS machines, but that's kind of the way it goes. The one big thing we have found, this has opened the floodgates for all things DVT. So PE was how we led things out, but now we have seen our DVT volume and even chronic venous volume go through the roof. So docs are referring things, and ER docs are calling, hey, you treat PE, do you also treat this? And if there's any interventional cardiologists or radiologists or vascular groups that are looking at implementing this in their institution as well, this can really open the floodgates to do a lot of that type of work if you're interested. So sometimes you say you got to be careful what you wish for, and be ready for the volume.
That's great. What would you say was the primary roadblock in getting Sanford's PE team up and running?
I think it was, well, I agree with most people here when it was the other, getting buy-in from all specialties. We had, like I said, that one pulmonologist who was really tough, and he was, an older one and influential, and that's what we found to be difficult, is when you have an older, more influential physician of a variety of specialties who can be very obtrusive, and they don't want, they think this is all hoofle and goo. They think that, changing the algorithms and advancing care is, where's the evidence, and so you show them the evidence, and they say, well, I want better evidence, and So we have a lot of these people, you know, that are just out there, and so that was a big barrier for us. And the other thing, honestly, was just the amount of work it took, being the champion and figuring out our committee structure, thinking what's the best way to get everybody on board, developing the guidelines. You know, I showed up for a committee meeting at 7 a.m. when I should have been, you know, doing my other clinical work. That took an hour, you know, four times, and then I think the fifth time we finally were agreed on it. But then I had to go around to all these different people and get their input. So doing that legwork was actually a barrier as well, you know, and that took a lot of time and effort out of other things I could have been doing. So, you know, your own motivation as a champion to get that done is a thing too, you know, and pushing through that, because initially you have a lot of excitement, but you got to push through and you know, deal with some negativity out there and break down some of those, you know, walls between specialties sometimes, you know.
Yeah. Do you have any advice or recommendations for facilities that have to manage multiple treating departments or multiple departments that are competing for the PE cases?
Sure. Yeah. If you have interventionalists, say a strong IR and IC group that both want to do this, I think this is where you have to, you know, you have to be a bit more democratic, and you have to say, well, you know, if both are interested in doing it and both have, you know, equal quality, well, I think both, you know, you almost just have to say, well, both can be involved. And I think having a member of each team on there and finding a way to triage patients appropriately between those two departments is the best way to go. That's probably the way to handle that. If it can be a little tougher if one of those specialties is kind of the champion pushing things forward, and, you know, it's, hey, us too. And that's kind of a situation by situation, and you have to be honest. You know, where are the skill sets at? And is one group, you know, whether that, you know, and that might be even vascular surgery may be interested in some situations, but maybe their skill set isn't where IC is or where IR is, you know. So I think you have to be honest about that. And I find, you know, reaching out and talking to docs one-on-one, finding the influential player in that department, and just, you know, grab a cup of coffee with them or just sitting down and talk with them for a minute. We do that very little in medicine, and I think that's very effective. You know, just a good conversation between guys without, you know, not in the setting of a formal committee meeting or some kind of meeting, just talking and saying, hey, you know, and working it out is that's where I've had success. You know, just using those interpersonal skills on a one-on-one basis with the right player in that department. You know.
Yeah, I get it. Let's see. Last question on PERTS is, how are you measuring your program's success on an ongoing basis?
So I showed you our retrospective review there, and we continue to update our database. So we look at all patients evaluated, and then treatment method, and then outcome. It's pretty simple. We look at, you know, complications. Bleeding complications obviously are big, but we look at complications, mortality, and then in follow-up, at that follow-up visit, you know, resolution of symptoms, and if people do get echoes, we don't get them across the board, especially in people that are just treated with anticoagulation, but we look at their outcome. And for us, that's important because, you know, you want to be sure that you're making the appropriate decisions. Are you missing submassives that you should have treated that went on and had bad outcome? Are you over-treating patients and you say, hey, we're probably dipping too far into people that have, you know, borderline findings, and maybe we can back off on some of those people? Are patients being not treated because of age or other types of factors when you say, well, you know, we treated 5 octogenarians who had severe symptoms or, you know, were clearly submassive, and we had no complications, so should we be considering those people, or are we biasing against certain groups? So those are the things that we talk about kind of on an ongoing basis. And now that we've kind of had a little maturity and some wind underneath our wings, you know, we've kind of had a lot of those conversations, and we'll revisit things more on a quarterly to you know, Q3 to 6 month basis at this point.
Sure. And what do you think are the top 3 critical success factors for starting a PE team?
Oh boy, that's a good question. Again, I think you got to have a strong champion, someone who's willing to put in the legwork. That's critical. I think getting buy-in from the key specialties, you got to get buy-in from the key specialties. And I mean, it's all about buy-in. So buy-in from the specialties and buy-in from administration. If you had a willing champion and you've got buy-in from specialties and the administration, your key administrator or administrators, that's the important thing. I think going on to developing your actual treatment algorithms and getting your specialties or specialty as far as treatment stuff goes set, that can all be filled in. But getting that buy-in from people is the key part, I think.
That's great. That's great. All right, well, now we have a couple questions on patient selection. So let's see, the first question, for submassive PE, how quickly are you taking patients for thrombolysis? By definition, they're more stable than massive PE patients. For example, if you place catheters at 4 p.m., do you come back to the ICU to remove them at 4 a.m.? Do you leave them in until 7 a.m., things like that?
Right, yeah. So we used to, especially when we started, we took every patient. Right when we saw it was submassive, we would take them and treat them. And we started to talk over the last few months, hey, if you get a patient that comes in at like midnight and they're hemodynamically stable, but they've got right heart strain, can we put that on in that 6? We kind of have a 6 and 7 a.m. slots in the morning for kind of overflow or emergency cases. Can we slip them in at one of those 6 a.m. slots or 7 a.m. slots in the lab and get them going then if we're going to treat them? And, put them on a heparin, obviously, get them anticoagulated and whatnot. And a lot of us were thinking, yeah, no, that's probably a reasonable thing to do. And in general, I think that is. I think that's a reasonable way to go. Likewise, when you're DCing catheters, initially, they were saying, oh, physicians or cath lab staff have to do that. Well, we went from having an ICU to kind of a step-down unit to do our stuff, and this is where the education piece comes in. Because taking out these catheters is very simple. It's much safer than taking out a swan. There's no balloon or anything like that at the end. And so now we have our ICU nurses, or step-down unit nurses, educated on DCing catheters and sheaths. That makes it tremendously easier. So we can check in on their clinical improvement and then DC the catheters. And that can be, that can be done around the clock now. So we don't have to wait till staff is in at 8. We were doing that when cath lab staff, and that was kind of our process. We'd wait, extend it a little longer and have them do it, when they come in. But if you can get your staff trained, then you can, you can stop the patient's approved and meet your clinical parameters. You maybe do a pressure measurement and meet that. You can DC that, anytime. And so that makes the backside a little easier if you can get your staff trained to that level. But one story, though, I had a colleague tell me this. It just happened this past month. He was on call. It was a Friday night. PE patient comes into the ER. He gets a phone call at like 8:30. It's the symptom. They had, they're on, 6-8 liters of oxygen. The PE was kind of moderate, and troponin and BNP were not impressed. He said, well, let's check an echo, which is our routine. So we checked an echo. Well, cardiology had 2 STEMIs come in, and they got the echo done finally at like 11:30 midnight. And one of those STEMIs was the second one. One came in initially, and then one was coming in right then. So our call team in the lab was a little overwhelmed, and it was 11:30 midnight, and the doc said, hey, let's just put this on at 7 in the morning, first slot Saturday morning. Well, the patient ended up coding at 6 and passed away. And so that has made us, kind of reevaluate. So we've gone back, and we're going back and looking at that case. Hey, what was really going on with this? Were there other things going on? Were they, in that situation? So that kind of is a situation where, it's kind of made us get pause that, the submassive mortality rate is real, and you don't want to change your whole program just for one patient, but it's something that, you get pause to. That I think a short, delay in getting things set up, if it's, wee hours in the morning and you want to delay a few hours to get things rolling, I think it's fine. But it's a serious thing we're doing, and so it's something we always have to keep our eyes wide open with.
Yeah, great answer. Second question is, if a patient is clinically stable, normal BP, normal heart rate, normal pulse ox, comfortable, however, they have a large PE burden on CTA and a dilated RV, do you still perform echoes?
That's definitely the patient you want to perform echoes on, yes. Yeah, the patient, if they've got a big dilated heart, those are the people that that this is, that's that submassive group. And that's what I think an initial thing, especially for the older school, physicians, is, hey, I've got this patient that looks good to my eye. Why are we going and doing anything procedurally on them? And that's the nature of it. You know, you could say the same thing about like a abdominal aortic aneurysm. Hey, that patient looks fine. Why are we going and doing a big aneurysm repair on this patient? You know, and that's the thing is that right heart strain is what leads to, you know, the patient decompensation. And you know, I've had a number of patients that'll come and they had their PE a couple of weeks prior. I had one guy who had his PE 4 to 5 weeks prior, and this was kind of back when we were getting our program rolling. By clinical history, that's the best I could get, and he had his PE diagnosed about 3 weeks, 3-4 weeks prior, based on the CT. He comes in and he's still having severe shortness of breath. A 41-year-old guy couldn't walk across the living room without getting short of breath. And you know, he was a guy that was not doing well with conservative therapy. We go back, we ice him the next morning. He walked in the hall saying, "I feel great, doc." So that's the patient that, you know, a young patient that can compensate acutely might not be compensating a month down the road, you know, or 2 months down the road. And that's the thing is you kind of that barrier to overcome in your mind, that's the patient you're really going to benefit.
That's great. So third question, what about the patients who have syncope with PE? Are they classified as massive or submassive, and where do they fit in to your treatment protocol?
Yeah, I think that's I think that's a little semantics. You know, if they're hemodynamically stable or hemodynamically unstable, if they're having some syncope, I do think that always raises my antenna a little more and will get me more to treat patients. You know, the patient that's their blood pressure and heart rate are fine, but yet they're on, non-rebreather mask to keep their O2 sats up. You know, that's another thing. So I think you got to look at the global situation and what makes sense. You know, patient comes in with syncope, they got a PE, but it's a very small PE. Well, maybe you shouldn't, pigeonhole your thinking and say, well, what other causes could, that could be going on here that we're missing. So I think, the more symptoms that they have, or the more acute symptoms or concerning, goes in the column of treatment. But
yeah, great. Let's see. We'll move on to a couple actually treating questions with EKOS. But let's see. First question: are you checking fibrinogen levels throughout the night, and what is your protocol to stop treatment other than major bleed?
Yeah, excellent question. So we do check fibrinogen we check a baseline and then one every 4 hours. And we found with our EKOS patients, our parameters are my line in the sand is 150. I want to keep the fibrinogen over 150. I think that's a pretty accepted number. One of my partners really goes by 200, but I think 150 is kind of an accepted number. That bleeding complications, if you keep your fibrinogen over 150, are pretty minimal. And with our treatment protocol we have now, where we use around 20 milligrams DPA, we haven't had to stop because of the fibrinogen. But then marks the question, well, should we be checking as much as we do? But we still do. We haven't gotten over that yet. Where we find fibrinogen issues is when we're doing DVT lytic or arterial lytic. We find a lot more troubles with patients tanking their fibrinogen. They'll start out at 400, 500, and they'll tank it down to 125. We do see that happening. I think then that you got to think about one thing is everyone will assume that you stop treatment. The other thing you got to think about though is how bad is this patient? How much do they need this lytic therapy? In a few situations, more so in like occluded vena cava, phlegmasia situations, I have continued lytic therapy and given cryo and brought their fibrinogen up. The patients have done well. But I kind of save that for that severe situation. If you have someone that has a massive PE and you got the lytic going and they're improving clinically and they drop in the fibrinogen, I would maybe say, well, consider maybe giving cryo and continuing your lytic therapy in a situation like that. But that's a pretty unusual situation that you get that.
Okay. Do you always treat for 12 hours? Do you ever treat for longer than 12 hours? And then finally, do you check CTA or echo the day after or anytime after that?
Yeah, so early on, and I think this is important, when you're starting your program, you're going to be a little more selective in who you treat. Potentially, you want clear patients, and you're going to check more things. Like I said, we brought every patient back to the lab and did an angio pressure measurement, and that was our initial protocol. And then we backed that off to checking an echo post with clinical parameters and a pressure measurement at the bedside. Now we've backed that off more and go off clinical parameters and maybe a pressure measurement. We don't routinely get an echo. The people that I'll get an echo for, at like the 12-hour point are the ones that had, that maybe were a massive PE or they had truly occlusive clot, very large clot burden. Those are the patients I'll check an echo on and judge whether to continue. I'll use that now at the bedside whether to go longer. That's fairly unusual though. With our current protocol, we found most patients will normalize and look quite good.
Great, yeah. And the last question I think you already answered, which was how long do you wait between stopping EKOS therapy and removing the lines in the sheath?
Yeah, we've gotten at that. We'll stop. Turn the machine off and then pull the sheaths right away. We'll just pull everything out right away, and then I'll say order up the, if we're doing like a Xarelto or EKOS, I'll say order that up and get it in them. So I'll want to get that anticoagulant in them immediately. And if we've been following fibrinogens, that gives you a little confidence that you didn't tank them too bad or hurt them too bad with your lytic. And so we'll get the sheaths out, get the Xarelto in, give them 2 hours down, and then let them get up after that. One caveat, technically, I will access most commonly in a greater saphenous vein, so I'll put my sheath in the greater saphenous and use that as my on-ramp to the deep system. So I don't stick the deep system directly. I found that also helps a lot when you pull your sheaths, just as a technical caveat there. That usually works really nice. It's a nice little trick you can do. But.
Wow, that's good. That's good to know. That's a nice tip. But that's it for questions. Thank you very much, Dr. Laurich.
Yeah, you bet. My pleasure.
Well, thank you, everyone. And on behalf of EKOS and Dr. Laurich, thank you so much for joining us today. Have a great rest of your evening.